Thank you, ma'am. Good morning. I'll be talking about pediatric orbital lesions. In this presentation, I have included both malformations as well as tumors. So, as we all know, pediatric orbital lesions, they differ from adult types. They differ according to the age of presentation. And the commonest pediatric orbital lesion we generally come across is the cystic lesion. And second most common is the vascular lesions. Rhabdomyosarcoma is the most common malignant tumor. I've divided the orbital lesions according to their age of presentation. Proptosis at birth is quite rare, and the various causes are microphthalmos with cyst, meningocele, orbital teratoma, capillary hemangioma, and rarely we come across pseudoproptosis. So coming to microphthalmos with cyst, as we all know, it arises from incomplete closure of embryonic fissure, and basically the eyeballs are microphthalmic, and generally it is bilateral, and this is what is the typical. On CT, you can see that the globe is shifted up and there is a cyst in the infranasal part of the orbit. This is a child with bilateral microphthalmos with a cyst on right side. Treatment is aspiration if it is a large cyst in children, say around less than 2 years. We do surgical excision generally when the child grows up, say around 3 to 4 years of age. This is the intraoperative picture. This is the cyst which is open, and you can see the connection here to the eyeball, which is situated in the supero-temporal part of the orbit. Coming to meningocele, meningocele is very rare, and as we know, it is basically meninges with spinal fluid which herniates into the orbit. The anterior meningocele is more common than the posterior, and this is a child with frontoethmoidal meningocele presenting with lacrimal sac mass. It's appearing as if this is congenital amnocele, but this child is suffering from anterior meningocele. So before we do any kind of intervention, we should always do imaging. This is a child who was having proptosis since birth. On imaging, you can see this is a meningocele and there is a defect in the greater wing of the sphenoid. This is the MRI showing the communication. Coming to orbital teratoma, a very rare entity characterized by rapidly progressive proptosis, which is since birth, and on imaging you see multicystic lesion with calcification or bone formation. So teratoma, as we all know, basically it arises from the 3 germinal cell layer, and the treatment is excision. This is a rare presentation in the sense that this was a child born with the dermoid. Dermoid generally you see around 1 year of age in children, and generally it is periorbital. This patient had double dermoid cyst, as you can see here. Lymphangioma as such generally presents in first decade of life, but this child presented with severe proptosis since birth, and you can see on imaging multicystic typical lymphangioma-like picture, and the cyst was aspirated, and this is almost 1 month after the aspiration. A very rare case which was reported by us, this is orbital melanocytoma. This child presented with proptosis since birth, and you can see the blackish lesion which is there, along with multiple nevi all over the body, and on imaging hardly any ocular structures visible. So this was a congenital melanocytoma, infiltrative in nature, and this entity can progress to malignancy. So exenteration was performed, and this is the cut surface. You can see no ocular structures visible. Glial heterotropia, again a very rare presentation. Generally the proptosis is since birth, which is gradually increasing, as you can see in this child here. And on imaging, sometimes you can confuse with lymphangioma because you can see the cystic areas. Sometimes septae also can be there, and the treatment is excision. This is just to complete the list. Pseudoproptosis, where the child is born with the proptosis but is basically having, premature closure of the cranial sutures, and you can see a typical cloverleaf skull. And in this, nothing much we can do except if there is exposure, we generally do tarsography in these patients. Generally, the neurosurgeon, they intervene. So then coming to orbital lesions of infancy to 2 years. In this category, I have kept capillary hemangioma as the commonest, followed by dermoid cyst, Langerhans cell histocytosis. Amongst malignant lesion in this age group, generally you see orbital retinoblastoma and metastatic neuroblastoma. Capillary hemangioma, we all know it's a true tumor, and it has got a proliferative phase, quiescent, and then involutional phase. And the treatment nowadays is oral propranolol, and rarely we need surgical excision. Dermoid cyst we know is a choristoma, and this is basically because of the sequestration of the surface ectoderm. And generally, the child in this age group presents with a periorbital, a well-defined mobile lesion, commonest site being supero-temporal in relation to frontozygomatic suture. So it is basically of two types. One is the periorbital, which is seen in this age group 1 to 2 years. The deeper one generally presents in young adults. And you can see here the CT showing fatty contents, very much suggestive of dermoid cyst. Treatment is to excise this in toto without rupture, but even if rupture is there, we should take out all the contents, and most important, cyst wall should be taken out. This is a young girl presented with orbital dermoid. Langerhans cell histocytosis, this is the most common of the histocytosis, and this can be unifocal or multifocal in the orbit itself. As in this child, you can see there is a proptosis. On imaging, you can see the lytic lesion with some soft tissue component. Generally, it is the lateral part of the orbit which is involved, the temporal bones. Here, the other side was also involved. So orbital retinoblastoma, we know that this is extraocular spread of retinoblastoma. As you can see here, the intraocular calcification with tumor, and there is a extraocular spread. And this is one of the delayed presentations of retinoblastoma. In our setup, around 37% patients, they present with this stage of tumor. And the treatment is that we give chemotherapy neoadjuvant, followed by enucleation, and then we have to continue with the chemotherapy and the radiotherapy. Then metastatic neuroblastoma. We should remember that in children, metastatic diseases usually go to the orbit, and in the adults, usually it is the uveal metastasis which is more common. And neuroblastoma is basically second to rhabdomyosarcoma as the most frequent orbital malignancy in children. And orbital involvement is seen in around 20% of children, and generally it comes from the adrenals. And as you can see in this child, bilateral proptosis with ecchymosis, a very typical presentation of metastatic neuroblastoma. And if you see the imaging, again, very typically it involves the lateral part of the orbit. And as you can see here, the lateral bones and the soft tissue component all around this. So this is typical, picture of metastatic neuroblastoma. This is another child. Again, you can see the temporal bones are involved with the soft tissue component. This is a post-chemotherapy. This I just wanted to highlight here because this is a very rare presentation, infantile hemangiopericytoma. Generally, hemangiopericytoma, they present in adult patient, but this was a child who presented in infancy, and this was highly vascular, so this could not be debulked. I just took the biopsy, and followed by this was treated by chemotherapy. You can see post-chemotherapy. This was the first case which was treated by chemotherapy, and that's why this was reported. Then coming to orbital lesions of childhood. So in this, the commonest we see in the first decade of life, say around 5 to 12 years of age, we see is the vascular lesion, which is lymphangioma, followed by dermoid cyst, then neurofibromatosis. These are all other rare tumors which can present in childhood. And amongst malignant lesions are these. Lymphangioma is basically a malformation. We should remember that. This can be lymphatic or venolymphatic. And this neither proliferate nor involutes. And basically there is ectasia. That's why the patient presents with sudden proptosis like this. And this is the typical imaging picture. And this is post-surgical. This is just to show the fluid level and multicystic nature of this lesion, which is very typical and helps us in diagnosing. This is the intraoperative picture. You can see clearly the chocolate cyst in relation to the eyeball. Coming to neurofibromatosis, this is a peripheral nerve tumor, and orbital features are seen both in 1 as well as in 2. Neurofibromatosis 1 is almost 10 times more common than neurofibromatosis 2. And these are some typical presentation. There is orbitotemporal plexiform neurofibroma, as in this child you can see, with biophthalmic globe. And you can also find this gliomas, leash nodules, and glaucoma can be there. 2, as I said, is rare, and there is generally bilateral 8 nerve masses, and you have a neurofibroma, meningioma, glioma, or even schwannoma can be found. As I said, it's a rare thing in this child. This is a case of neurofibromatosis 2. This is a huge schwannoma which is present here. This is neurofibroma here on the scalp, as you can see. This is the imaging showing mainly cystic cavity, and here you can see the meningioma lesions also. Hydatid cyst again can present in young children, and this is a parasitic infestation caused by echinococcus, and humans get affected when they are intermediate host, and generally the patient presents with a massive proptosis, and you can see that usually it is in the superior part of the orbit you see the hydatid cyst, or it is in the retrobulbar region. Ultrasound sometimes shows you the typical double wall sign which is described by Dr. Biteria. And the treatment for this is excision of cyst. This is a small video. This is the transconjunctival root removal of the hydatid cyst. You can see the pericyst has been dissected, and what you see as whitish thing, just like the white of the egg. This is the ectocyst. The aspiration has already been done, that's why it is collapsed. Then you place the cryoprobe on the cyst, and through a very small port, such a huge hydatid cyst can be taken out. You have to be little patient while you are doing this, otherwise you can rupture the ectocyst of the hydatid cyst. So it has been completely taken out. If there is little bit spillage, then you should do a nice, wash, and even you can give oral albendazole in the post-operative period. This is the gross specimen of the same, and this is the post-surgical picture. Coming to glioma of the optic nerve, this is a low-grade juvenile pilocytic astrocytoma, and generally seen in children. Here I would like to highlight that when a child with glioma comes like this, you should always differentiate whether it is associated with neurofibromatosis or not. And the common one is non-neurofibromatosis, which is a discrete glioma like this, as you see here. And associated with neurofibromatosis, generally they are diffuse multifocal. The progression in these patients associated with neurofibromatosis is very slow, and the visual acuity is also stable, so you can observe in these patients. But in non-neurofibromatosis, generally they present with poor vision, and they progress little faster than those associated with neurofibromatosis. And the treatment is observation if the vision is good and stable, surgical excision if the glioma is limited till the orbit or the pre-chiasmal area. If chiasma is involved and surgical excision is not possible, then you have to give chemotherapy along with radiotherapy, and if there is hydrocephalus, then sometimes shunting procedure needs to be done. Rhabdomyosarcoma, most common malignant tumor, as you can see here, generally in first decade, presents within few months, a very fast growing tumor. Generally the bone is not involved in rhabdomyosarcoma, and our role is limited till the biopsy, but rest treatment is done by the chemotherapy and rarely radiotherapy. This is pre-chemotherapy, this is after the chemotherapy. Leukemia granulocytic sarcoma. Granulocytic sarcoma is a localized extramedullary form of AML. Leukemia is when you see the systemic involvement also. A very typical presentation like this, bilateral involvement. And on imaging, it's quite easy to diagnose because usually the superior part of the orbit is involved in leukemia. Generally one facial plane is involved, as you can see in this particular child. Then metastatic In this age group, say around 10 years of age, it is the Ewing sarcoma which should be kept in mind. Unlike neuroblastoma, which generally present in less than 5 years age children, Ewing sarcoma, again it presents like a sudden proptosis, and generally it affects the long bones. Rarely, primarily, it is seen within the orbit also. This was a series presented from our center, so I wanted to highlight this. This was a 10 years study, less than 16-year age from a pathology department. The patients were included. We found that the malignancy was slightly higher than the benign lesion in our setup. And amongst the malignant lesion, it was the myogenic tumor followed by the other lesion, metastatic and secondary orbital tumors. And amongst the benign lesion, it was the vasculogenic followed by cystic and other lesions. Thank you.